A very warm welcome to all of you. I am Dr. Manish Verma. I head the Sanofi Medical Affairs. So it's my pleasure to welcome you all on this wonderful evening. You all know that Sanofi has been pioneering in bringing cutting-edge science in the respiratory disease management, especially the allergies. The upper respiratory allergies and the lower respiratory allergies we combined around 2-3 years back when we started doing programs around United Airway disease. ARIA is a very similar concept which is about allergic rhinitis and impacts on asthma. And no other than Professor Jean Busky is here today to talk about the concept, the new guidelines which have come. So we will be hearing him from very soon. Today we have audience in this hall, plus we have audience at around 11 webcast centers. So they are also watching us. So you will see which are the centers and who are the people also in between. We will invite them. My colleague Rahul will introduce the chairperson at those centers. We will also take Q&As from those centers. So it's my pleasure to invite them as well. And without further ado, I will request my colleague Dr. Rahul to come on the dais. He will introduce the webcast center chairpersons, today's speakers and chairpersons. Thank you. Starting the session, so may I request you to please take your seats. A very warm welcome to all of you. I am Dr. Manish Verma. I head the Sanofi Medical Affairs. So it's my pleasure to welcome you all on this wonderful evening. You all know that Sanofi has been pioneering in bringing cutting-edge science in the respiratory disease management, especially the allergies. The upper respiratory allergies and the lower respiratory allergies we combined around 2-3 years back when we started doing programs around United Airway disease. ARIA is a very similar concept which is about allergic rhinitis and impacts on asthma. And no other than Professor Jean Busky is here today to talk about the concept, the new guidelines which have come. So we will be hearing him from very soon. Today we have audience in this hall, plus we have audience at around 11 webcast centers. So they are also watching us. So you will see which are the centers and who are the people also in between. We will invite them. My colleague Rahul will introduce the chairperson at those centers. We will also take Q&As from those centers. So it's my pleasure to invite them as well. And without further ado, I will request my colleague Dr. Rahul to come on the dais. He will introduce the webcast center chairpersons, today's speakers and chairpersons. Thank you.
To one and all. We will begin with the webcast centers first. So I warmly welcome all the webcast centers which are spanned across 11 different cities. From Bolpur, we have Dr. A.R. Guha, he is an ENT surgeon. From Kontai, we have Dr. Anustup Patnaik, he is a chest physician. From Faridabad, we have Dr. Lalit Kumar Hasija, he is an ENT surgeon. From Ghaziabad, we have Dr. B.P. Tyagi, otorhinolaryngologist. From Hubli, we have two chairpersons, Dr. Arun Kumar, ENT surgeon, and Dr. Sachin Kinnarkar, pediatrician. From Hyderabad, we have Dr. G.V.S. Rao, he is an ENT surgeon as well. From Karimnagar, we have Dr. C.H. Lakshman Kumar, professor and HOD, and he is a pediatrician. From Kurnul, we have Dr. Fazul Rahman Khan, he is an ENT surgeon. From Patiala, we have Dr. K.G. Goel, he is a pediatrician. From Udupi, we have Dr. Balakrishnan, he is an ENT surgeon and also heads the KMC Manipal unit there. From Vijayawada, we have Dr. Shingari Prabhakar, he is an ENT surgeon as well. Now we come to our life center, which is Bangalore here. I would like to welcome and take an opportunity here to invite Dr. H. Paramesh. We all know him and he's been pioneer in different sets and also widely known as an environmentalist. He's a pediatric pulmonologist by professional education and qualification, currently past president of Pediatric Association of India, involved in preparing many training modules to the UGs, to the PGs, and also to the likes of DNBs in asthma, allergic rhinitis and its comorbidities, pediatric sleep, airway disease education and expertise, controlling in asthma pediatric population through, like I mentioned, in education and research. His areas of interest typically very much overlap with whatever leadership and thought we have in developing ARIA and in developing it in the Indian context. So airway diseases, the climate change, air pollution, prevention of allergies based on social determinants of health. He's also closely working with the health authorities of India and the Air Pollution Control Board. Our next esteemed Honorable Dr. Deepak Haldipur is the chairperson for today along with Dr. Parmesh. He is a senior consultant ENT surgeon at Fortis Hospital. He is also President-elect Association of Otorhinolaryngologists of India, AOI 2016. Specialized in microsurgery of ear, endoscopic sinus surgery, rhinoplasty, microlaryngeal surgery, HNF surgery, cochlear implant. And definitely with such credentials, he also is immortal typically, just like other dignitaries here in the research field, and has several publications to his credit. So with that quick round of introduction to one and all, I would now like to welcome Dr. H. Paramesh on stage to kindly introduce Professor Jean Abuski.
Good evening, everybody. Of course, this is one of the important topics what we want to talk about, United Airway Disease. To talk this subject, we have one of the pioneers in this one. And you already received the brochure, you read all about it. I want to have my personal experience with him. I first met him in 2008 in Delhi when I discussed about the airway diseases and all this thing. Half a day discussion, we all had it. Then 2010, I met him in London. During that time, we were trying to prepare allergic airway disease, allergic rhinitis comorbidity module. We include ARIA guideline predominantly. And I have to quote here, he was the first chairman of the GINA guideline. During that time, he wanted to include allergic rhinitis. The committee said, if you want to include allergic rhinitis with asthma, you have to step down from the chairmanship. He threatened. He was threatened. And he took boldly. After this, preparing that one, he took over ARIA guideline. That became more popular. You cannot wheeze without a sneeze. You don't have a sneeze without a wheeze. I think it's a true fact, as a matter of fact. That's what he prepared. We have the great man to coming over here. In addition to this, I like to say that allergic airway diseases are the early onset, non-communicable environmental disease, I would say that. It's a global phenomenon, as a matter of fact. I think it's a global epidemic. Recently retired Margaret Chan of the WHO says nearly 1 billion population suffering with asthma now. It's going to be 4 billion by 2050. And allergic rhinitis has become earlier, chronic cough from allergic rhinitis, from 10% 17 years ago, now 2017, it is almost 72%. Allergic rhinitis is becoming more and more. I think these are all non-communicable diseases. Compliance is better. To better compliance, we need the coordination link between the patient, parent, and physician. The science has to progress. The science has to progress. We have the coordination link between the practitioners, academician, researcher, and pharmaceutical company. Without them, we cannot progress. Believe me, what we are talking about it. So we can progress with them. Let us keep our ethics. Let them keep their ethics. And I'll be thankful for Sanofi making this opportunity so that we can meet one of the world authority on allergic airway diseases. I have a great pleasure welcoming you to sir. It is for you. Thank you.
Ladies and gentlemen, it is my great pleasure to be in Bangalore. It's my first time to this marvelous city. And I'm also delighted to be with the chairman, Professor Paramesh, because he has done such a great job on air pollution. He did that a long time ago. And this is why this is so important, because he saw many years ago that airway disease and air pollution would not go together. Well, this is not yet totally understood, but now, thanks to people like you, we are moving into the right direction. I would like to discuss ARIA 2017 because ARIA was allergic rhinitis and its impact on asthma, and what you said about Gina was true. I was not the first chairman, but I was the chairman at that time. And you know, Claude L'Enfant told me, if you don't comply to my satisfaction, not doing rhinitis in asthma, I fire you, and my answer was simple. I just comply to the satisfaction of my patients. And my patients have rhinitis and asthma, so I will do rhinitis. And I was fired, but that's not a problem. Well, I would like to discuss with you 5 points today. First of all, United Airway Disease, yes, but. Second, ARIA from 1999 to 2016, because now we are going into a direction which differs from guidelines. ARIA 7 2017, from guidelines to integrated care pathways, and this is what we need to do. And then I will discuss the algorithm for the treatment of allergic rhinitis, the pharmacotherapy and immunotherapy. And finally, do we need future therapies or better management? So let's go to United Airway Disease, yes but. So this man was the first who described allergic rhinitis in 1819. This is the true date, 1819 in London. And John Bostock said, every year I have conjunctivitis, sneezing, and asthma. So, to say that asthma and allergic rhinitis are not going together, it's a mistake, because it is not now 200 years ago. So I'm going to give you 2 or 3 slides showing the magnitude of the problem. Well, this is a study we performed, and to our surprise, there was a high rate of rhinitis in asthma, but both in atopic subjects and non-atopic subjects. And this is very important because it is not allergy which is inducing the multimorbidity, it is a different disease. And this is the first time it was found. With the same group, we studied asthma prevalence in rhinitis patients. And what we found, it is that if you have no rhinitis, there is no asthma. No asthma and no rhinitis. In seasonal rhinitis, you have 6% asthma. In perennial rhinitis, you have 10%. And when you have persistent rhinitis, seasonal and perennial at that time, you have 16%. So this is what we know and we knew at that time. Well, it was 15 years ago. And then there are many other studies. I've selected 2 others for you. The first one is a study by Stefano Guerra, and I'm delighted to tell you that today I got a paper on PubMed with this gentleman, so it's good to see that you can make studies later. It is on cell biology. But rhinitis was found to be an independent risk factor for adult onset asthma, both, again, in atopic and non-atopic subjects. So, again, the links between rhinitis and asthma are not associated with allergy only. And he found that in moderate and severe rhinitis, the trends were far higher to get asthma. The last slide I want to tell you on this historical background was the paper we published with David Price. It was in something like 27,000 subjects. And what we found, it is that the percentage of hospitalized patients is increased in multimorbid rhinitis and asthma. So, to have rhinitis and asthma is not only an association, it is a synergy. Now, I would like to say yes, but. I like that because, it's not only yes. So what I'm going to show you, it is a cell phone application. We completed, it has started 2 years ago, and now we have the first data. So what we ask the patients is, how are you today? And well or not well? And then, how are your nose symptoms bothering you today? How much are your eye symptoms bothering you today? How much are your asthma symptoms bothering you today? And with these 4 questions, we can make a lot of information. Well, first of all, you can see that there is a very high correlation. In 42,000 days, correlation 0.87, between how are your allergy today and what is rhinitis. So rhinitis has a major impact on the global evaluation. But this is a very new slide because the paper has not yet been submitted. It is in 32,500 days, so it's a lot of days. And what you see in green is rhinitis. So as soon as you have some symptoms, you have a high rate of rhinitis. In orange is work productivity. And this is very important because the government say, well, rhinitis, you scratch your nose, you have rhinorrhea, it doesn't matter. But look, work productivity is considerably impaired in these patients. And then we have conjunctivitis and asthma. And here, there is a phenotype of rhinitis, severe rhinitis without asthma. We need to better understand this phenotype because possibly this will need a different treatment. So, rhinitis and asthma go together, but not in all patients. And if you assess the severity, well, I think that this line is absolutely perfect. I told you that rhinitis was quite well associated. And then you have here the work and asthma and also conjunctivitis. This is almost similar, but look at asthma severity, again it decreases. So there are some patients in whom there are differences between the nose and the lower airways. And in fact, there is a major difference between asthma and rhinitis. And this is a very important slide for mechanisms. In fact, in the embryo, you have the endoderm, the mesoderm, and the ectoderm. The mesoderm is leading to the T2 response, and this is due to the multimorbidity, whether it is allergic or not. The lungs are from the endoderm, and the nose is from the ectoderm. This is why there is no remodeling in rhinitis, and there is remodeling in asthma. If you had remodeling in rhinitis, you couldn't breathe because you are, well, in Bangalore, you are always insulted by pollution. So if you had remodeling, your nose would be totally blocked. And it is not. And this is due to endodermal and ectodermal origin. Well, I don't have time to discuss this, but this is a very important research topic in my group now, because what we want to do is to assess whether there are links between endoderm and mesoderm which may explain the severity of asthma. So you see, allergic rhinitis and asthma, yes, but not completely. Now, ARIA from 1999 to 2016. So, what I said to Claude L'Enfant, I'm going to do ARIA, and WHO approved and agreed that we could have a meeting at WHO. And ARIA started with WHO, and it was with the WHO Collaborating Center. I chaired for 14 years. When I retired, I couldn't have any longer this collaborating center because now I'm a bit older than the retirement pattern. So ARIA was started in 1999. And it was quite interesting because I think it is the first multimorbidity guideline in chronic diseases. At that time, no one was speaking about diabetes and heart disease. No one was speaking about this. And it was 20 years ago, and we had that. So first of all, it is a state of the art for the specialist, the general practitioner, and for the healthcare workers. And I would like to say now for the patients as well, to update their knowledge of allergic rhinitis, to highlight the impact of allergic rhinitis on asthma, to provide an evidence-based document for the diagnosis and the treatment, and propose a stepwise approach similar to GINA. But we had something very different, and it is this: to assess the magnitude of the problem in developing countries and to implement guidelines in these countries. Well, 20 years ago, I was speaking about allergic rhinitis in India. Very few people. Today, it's a very common disease. So ARIA was very new in its concept because 20 years ago, well, not exactly, 18 years ago, we envisaged that developing countries would be a major topic for rhinitis. And now, what I want to show, it is that rhinitis is not impacting severely the health. It's not a severe disease, but it is impacting the health of patients. Because when you have rhinitis, when you cannot breathe, I tell you, quality of life is more impaired by rhinitis than by asthma. Work productivity is more impaired by rhinitis rather than asthma. So rhinitis, due to the enormous number, may become a very hot topic in the future. I'm working on that now. So ARIA workshop was published in the Journal of Allergy and Clinical Immunology. We had 52 languages translated, and I would like to say that Ruby Pawankar made the translation of at least 15. She was very active there. And we had also the update, which is the best cited paper in rhinitis. And finally, we changed it. We thought that the evidence-based model was not sufficient. And we went to the GRADE evaluation. And I'm sorry to say that not all guidelines now are using GRADE. So this is a paper with a supplement of 560 pages. Just because if you want to read what were our evidence-based decisions, you can read everything. And you can say, well, you have missed this paper or not. So the supplement is fully published and everything is there. So this is very important because it has been accepted by governments and by regulatory agencies. And in fact, what are the conclusions? Well, first of all, should H1 antihistamines be used for the treatment of allergic rhinitis? In patients with allergic rhinitis, we recommend new generation oral H1 blockers that do not cause sedation and do not interact with cytochrome P450. There are not too many. You have desloratadine and you have, fexofenadine. Because levocetirizine does not interact, but it is partly sedative. So then it is, in patients we suggest new generation if they cause sedation, some sedation. So in fact, there are two medications which are in this group, desloratadine and fexofenadine by alphabetic name. Now, I cannot refrain to show you one of my studies because I was the lead author of this paper, and we compared placebo, fexofenadine 120, fexofenadine 180, and cetirizine 10, and as expected, fexofenadine and cetirizine are similarly effective. However, if you look to the sedation rate, cetirizine is significantly increased. So this shows that our guidelines were right on target. Now, this is something I believe that Indian people should read more, because I know that still sedative first-generation H1 blockers are largely used. And, well, we recommend not to use them because this sedation can induce car accidents or many other things. So we think that you should go to the first-generation one, to the second-generation one, and not to stick with the second generation. Of course, intranasal glucocorticosteroids are very effective, but this is also interesting because we're able to differentiate between adults and children. And you know that intranasal corticosteroids are less effective in children than in adults. And many other studies have shown that now. So these ARIA guidelines were able to differentiate between adults and children when it was possible. And we didn't have any information on old age people. But now, allergic rhinitis is reaching this population. And it is very important to assess old age people. As I told you, ARIA has been approved by governments, but also, and this, this is the latest revision. I'm not going to discuss it because it's a bit complex, and I think that the great approach is probably better for placebo against a treatment rather than between two treatments. This is a bit too complex. But what I would like to say is that now ARIA is with Euphoria in Belgium. It was initially in the US, but Dr. Graz unfortunately died. So it's now in, and if you want, you could go to this website because I think you have plenty of information to be there. So now, okay, ARIA was a guideline. Now, it's not any longer a guideline. It's more than that. Because in India, how many GPs use guidelines? 5%? 10%? Lower. Okay. So if you are working like hell for 20 years and that no one used that, it's a disaster. So we need to go further, and this is what I'm going to show you now. Well, this is what we published recently. There is no Indian person here. There will be in the next edition because I am here to develop the ARIA India. So it will be done on Sunday. It is Sunday. Okay, thank you. And thank you for Avantis to help us. So look at the title. Care Pathways, Implementing Emerging Technologies for Predictive Medicine in Rhinitis and Asthma Multimorbidity Across the Life Cycle. So we are not any longer a guideline. We are a care pathway, and I'm going to tell you what is a care pathway, with cell phones and computers, but cell phones for patients. And I've shown you some data. In rhinitis and asthma across the life cycle. And I would like to say with real life data. Because this is modern medicine. Well, the group is Integrated Care Pathways for Airway Disease, and these are three departments of the European Union and WHO. So, in fact, we are doing this as a big undertaking. Well, it has been listed by the European Innovation Partnership on Active and Healthy Aging. So we are fully part of this, and we got 3 EU grants for that. The last one is on air pollution and rhinitis, which was accepted this week. This is the key slide of my presentation. When you have a patient with allergic rhinitis symptoms, first of all, many people do not know that they have rhinitis. And this is a major problem. But those who know they have rhinitis, they are doing self-management. I tell you, with this cell phone, 10,000 users, we found that no one is following guidelines. So it's not even 5%, it's no one. People treat themselves when they have symptoms. They stop immediately when they do not have symptoms. And I will show you a slide from someone I know, it's me. I'm doing exactly the same. So if I'm doing the same, I'm not following guidelines. Who has rhinitis in this room? Raise your hands. No one? It's impossible. Higher, higher. Raise your hands. Well, you are not in the normal population. There are some people here who didn't raise their hands. Who is taking intranasal corticosteroids? Intranasal corticosteroids. Do you take them regularly or at demand? Sorry? When you need? For 2 months, okay. And here, you have mite allergy, but when you have pollen allergy, people do that on a daily basis. So, the guidelines and all the documents in rhinitis tell you you should treat the patients regularly. And people use them when they need. You start when you need, you stop when you don't need. No? Sorry? Can you speak louder? Okay, so I think this is the key. So self-management is essential. And then the pharmacist. I know that in India it's not exactly the case because the pharmacist has much less. In France, for example, all patients go to the pharmacist first. Because to get a prescription it will take a month. So they go to the pharmacist immediately. And then you go to the primary care physician, to the specialist, and to the emergency care for asthma. And this is, I think, a very important slide because you need to use the same system across to be comparable. So what we proposed was an algorithm for the treatment of allergic rhinitis. And this has been published in the Journal of Allergy and Clinical Immunology a year ago. And in fact, what we wanted to do is to say, well, can you propose a strategy of treatment? And the strategy of treatment is the following. If a patient is not well controlled and no treatment, well, we propose a visual analog scale, and it works beautifully. If you don't have a visual analog scale, you take a line and you ask the patient, where are you? Well, not well. And if the patient is 5 over 50%, then the patient is not well controlled. And this is very easy to be done for the control of the patients. So, if the VAS is less than 5, you start a treatment, and you can start any treatment you want, but usually people prefer to take an oral drug, at least in my country. I think it is the same in your country now. People prefer oral or intranasal drugs? Oral, okay. So, you start with an oral drug. And this is why we put this. But some people want an intranasal, so why not? If the VAS is over 5, if the rhinitis is intermittent, you take any treatment. If it is persistent, we suggest intranasal corticosteroids because the symptoms have been for a long time. But you can add as well some oral drugs at the same time. Now, you reassess daily your visual analog scale using this system. And in fact, I can tell you, I've analyzed at least 3,000 patients. And when they are not well, they increase. And they take 4 or 5 treatments a day. And when they are well, immediately they stop the treatment. So, this is probably not day 3, but probably very quickly. If the VAS has decreased, then if the patient is symptomatic, you continue the treatment. If there are no symptoms, I tell you something. If there are no symptoms, you can say your patient, continue your treatment. No one does that. We need to be practical in our life. Now, if you have a VAS over 5, you step up your treatment and you reassess your symptoms to 7 days. If you have over 5, then you consider immunotherapy or you consider another disease. So you see, it's not any longer something simple, it becomes more complex, and I will tell you how we handle this. The next step is that you have treated symptomatic patient. This is mostly the case you have in your clinic, I'm sure. If you are a specialist, you don't have people with mild disease, you have people with severe disease. And in this case, if the VAS is less than 5, again, you have first-line treatment, differentiated between intermittent rhinitis and no exposure, and persistent rhinitis and allergic exposure. And we should add probably very soon air pollution. Because when you have air pollution, you have a different type of rhinitis. It's more an obstructive type than rhinorrhea. And in this country, more than in my country, because we have crowded cities, air pollution is quite high, and also because of the very damp climate. So, you maintain a step of the treatment and you reassess your VAS. Then, if the S is over 5, it's exactly here. Well, you go more commonly to intranasal corticosteroids or combination, because you have a combination in India. By the way, you know that the Indian combination is the combination which is sold by Mylan now. Dimista is marketed by Cipla. So, you know, Indian companies are doing extremely good job as well. And you reassess daily. If you have VS less than 5, it's this. If you have VS over 5, it's this. Well, you're going to tell me this is very complex. Not at all, because now it is in tablet. So all this is in tablet. And the physician or the pharmacist can use it. And it is totally free of charge. Well, in India, because in France we don't have that combination, there is a combination between montelukast and fexofenadine. In France we don't have this combination for a major reason. Montelukast is only approved in asthmatic patients with rhinitis. Why? Because in Europe, the authorities said, well, to MSD, if you want a product for rhinitis, we decrease your product by 2/3. And they said, well, we want a product for asthma, and we'll have less rhinitis. So, So here, it's very interesting to see that a study has been done, a randomized control trial. I think this one is from 2013, yes. And it was shown that montelukast plus fexofenadine is better than montelukast plus levocetirizine. Well, it's interesting to have one paper, but it is more interesting to have two. And there is a second paper, which was published very recently. I think it was in 2016, November, December, yes. And it showed exactly the same data. So the combination between fexofenadine and montelukast is quite effective, and you are lucky to have it in India because we don't have it in Europe. Well, I told you that, in fact, this is the way we're doing our algorithm. As you know, this helicopter is the only one in the world to do a looping. But when it does a looping, it is not any longer the pilot who is making the looping, but an algorithm made by IT. And we have used exactly the same company who made this algorithm to do the algorithm for our ARIA guidelines. Now, immunotherapy. Well, immunotherapy, we have two ways of doing immunotherapy, the SCIT and the SLIT. SCIT is subcutaneous and SLIT is sublingual. My problem is that up to 2011, there was no single SCIT immunotherapy treatment which was reported well. It was reported, well, the studies are not good. And there are very, very few studies on SCIT immunotherapy which match the criteria. On the other hand, in 2011 there were 4.2% of SLIT studies, but now we have many more. And in fact, this is a SLIT study with Stellargen product, and you see this is the low dose, this is the high dose, and you can see that there is a significant difference between placebo or low dose and high and very high dose. This is a study from LK in ragweed, and again, you can find exactly the same things. And you have now something like 15 studies from LK and Stellargen confirming this, so that they have been approved by FDA and EMA. So we have only SLIT studies approved by these big organizations. And it was, April 1, April 11, April 17, the same year. So the same year, 3 products have been approved by EMA and by FDA. In mite allergy, because I know that in this place here, 75% of your patients are allergic to mites. And in mite allergy, this is simple. the same occurs. This is low dose, this is high dose, and this is placebo. So, clearly speaking, SLIT is effective in mite allergy, and this is the EMA, which was in 2015. What is very interesting, it is here. It is persistent, moderate or severe house dust mite allergic rhinitis, despite use of symptoms relieving medication. And this is the exact wording of ARIA 2008. So ARIA is used by regulatory agencies in order to accept drugs. Now, do you think it is future therapies or better management which is important? So, what do you think? Do we need in allergic rhinitis new treatments, or do we need better management? Congratulations, this is true. Because in fact, before we have a new drug, it will take 10 years. A better management, it can take tomorrow morning. And this is another program we have from the European Regional Development Fund, so we got a lot of money from the EU. So, this is the modern approach of medicine. You take the genes, and the genes, and then you are doing networks. Well, we have done that. And we have a big program with, we got 16 million euros, and it is a success story of the EU. So I cannot tell you this is not the future. But the future is this: the finger approach to manage allergic rhinitis. And everyone can use the finger approach. And since you need only a vision log scale, it is translated in all countries within 5 minutes. And this is what we have done. So, again, I'm coming with this, and we have a cell phone for the patients and a tablet for the doctors and the pharmacists. And this tablet gives immediately what treatment is needed. For GPs it's quite interesting because it takes 2 minutes. And then, well, this is myself. It takes 20 seconds to go from your cell phone to your computer and to get the full data over 1 year or more with the control of the disease and all the medications you have taken. And I think that this is very important for doctors, because then the patient tells you, this is my sheet. And then you can see within 30 seconds how the patient is controlled or not. And this is the system. And these are the countries who are involved. We are now in 22 countries. So, I'm going to show you that it works. So we asked the patient, what are your symptoms? Runny nose, itchy nose, sneezing, nasal blockage, red eyes, itchy eyes, and watery eyes. And these are the ARIA questions. They affect my sleep, they restrict my daily activities, they restrict my participation in school or work, and they are troublesome. Very simple. I'm asking you a question. Do you think that if you have 3, 4, 5, or 6 of these symptoms, you are going to be worse than if you have 4? Well, no one knew. And very, very interesting data. Here, you have no troublesome symptoms, and this is for work, productivity, this is for daily activities, and this is for sleep. If you have troublesome symptoms, they are much worse. If you have nasal congestion, you have nasal severe, it's much worse. But for ocular symptoms, whether you have mild symptoms or severe symptoms, it doesn't make a difference for sleep. And that's normal. It's because you have nasal obstruction that you cannot sleep. It's because you are stretching your eyes and that you cannot work properly. So this system makes it possible immediately to tell you very interesting things, and I have no time, but there are 6 papers now in the row. Second, we did visual analog site management, and we took 3,000 patients here. And we assessed the vision scale. So very interestingly, those who are untreated have a better control than those who are treated. That's normal, because when you have no symptoms, you don't take medications. But we could fool with this system. The second thing is that, well, intransvagal corticosteroids are better than these antihistamines, but we didn't have the montelukast fexofenadine combination. I'm very sorry for that. And if you have monotherapy versus polytherapy, you are always worse. So people increase their treatment when they are not well, and they increase the treatment as much as they can. Sometimes they take 3-4 medications. Sometimes they take 2 oral H1 blockers, 1 sedative, 1 non-sedative. They may take montelukast, they may take intransvagal corticosteroid, they take everything. And in fact, at the end of the day, they're not better. So this system tells you exactly what are the patient needs. So ladies and gentlemen, I've tried to show you that in fact ARIA is something which is not any longer a guideline, but we are moving forward towards, well, what I would say modern medicine. Thank you. So now,
thank you so much, Professor. Thank you so much, Professor Buski, and thanks for a very patient listening to all the audience. Before we move on to the Q&A session, we have a very short commercial break. So a bit of 5 minutes of your time on the video presentation from our side, please.
Hello and welcome to the Health Hour. This is your host Bharti Kumaria, bringing you the latest updates from the health world. To begin with, the newest buzz in the market is GST. From 1st of July, GST has affected various sectors in different ways, but we turn our spotlight on the health sector. It is expected that GST would have a constructive effect on the pharma sector. There are hopes to witness a promising development in healthcare. Moving on, monsoon has set in India. Torrential downpour, particularly over Mumbai, Delhi and parts of Gujarat, has affected the cities along with its people. And with the rain and increasing pollution, allergy season has set in. Rain boosts allergens like pollen and mold, causing runny noses, thus triggering the condition of allergic rhinitis. Ignoring symptoms like sneezing, nasal itching and obstruction can impact quality of life and hamper day-to-day activities. We interrupt this bulletin with the breaking news. Reports have just come in that pharmaceutical giant Sanofi has crossed yet another milestone. For the very first time, Sanofi's hugely popular anti-allergy brand Allegra M has been endorsed for its quality and innovation, and the reports are published in the renowned Indian Journal of Pharmaceutical Sciences. Allegra M, the #1 fexofenadine montelukast drug, is used to treat persistent allergic rhinitis. The published reports talk about the bioequivalence of this combination. Over the years, Sanofi constantly innovated and improved upon Allegra and developed Allegra M in 2013, the first ever bioequivalent bilayer tablet. This publication is a testimony to this remarkable feat. The Indian Journal of Pharmaceutical Sciences has recognized this very innovative spirit. And for more on this breaking news, let's have someone from the house of Sanofi who has developed this formulation of Allegra M, Dr. Praveen Kullar from Goa Development Center. Dr. Kullar, welcome to our show and congratulations. How do you feel on Allegra M's endorsement in Indian Journal of Pharmaceutical Sciences?
I'm extremely delighted for such an endorsement and high quality results done at a CRO approved by US FDA. And we got a perfect matching with the individual reference product.
Can you tell us more about Allegra M's manufacturing process and how you were successful in developing such innovative and high quality standard formulation?
Allegram is developed by innovative team using a very innovative granulation process. Fexofenadine granulation is done in an inert gas atmosphere. Montelukast granulation is done in a very selective light conditions. Innovative bilayer technology is used to get the most stabilized formulation.
Dr. Khullar, please share your insights on how Allegra M is better compared to other molecules in the market.
Allegram has got perfect dissolution mapping compared to the reference. Allegram also has a low sulfoxide content as compared to the other brands.
So can you tell us your mantra on commitment towards quality?
We manufacture Allegra M in a EU GMP facilities using a very strict in-process controls and also validated processes. All the raw materials come from a highly qualified vendors, and the goodness of two reference products in one is going to give enhanced patient compliance.
Thank you, Dr. Khullar, for taking the time out to tell us more about Allegra M. Also, I would like to congratulate the Sanofi team on this wonderful achievement. So be rest assured, as now if it's about quality and innovation, the answer is Allegra M. On this note, this is Bharti Kumaria signing off. Stay happy, stay healthy, and remember, when you think of trusted anti-allergy drug, think Allegra.
Been developed in-house in India. So it's something which we wanted to share with all of you. There are reprints which are available as well, which we'll all share with you. I would now like to invite Dr. Deepak Haldipur on the stage, and just so that we witness all of it here and have a very symbolic unveiling of this moment of pride for all of us. So may I request Dr. Deepak Haldipur and Professor Buski for a very small unveiling for this bioequivalence feat that we have achieved for Allegra M. So please.
What is that?
Thank you so much, sirs, and now we leave the floor open for all the Q&As. Also, a big thank you to all the webcast centers for their patient listening. And what we are also doing is take the questions from the live center as well as from the webcast centers. So please feel free to send across the questions, and our chairpersons would be happy to answer it. Thank you so much.
There is a question here.
I'm Dr. Gayatri. I come from an ENT and an allergic specialist too. I have two questions. One is role of pre-probiotics in management of allergic rhinitis.
Of what?
Pre and probiotics.
Oh, pre and probiotics. Well, we have done a study on that. And in fact, we found that with one of the probiotic, there was a reduction, an improvement in quality of life in patients treated by loratadine, because I said that we couldn't leave the patient without treatment during the pollen season, and we found an improvement of quality of life. So yes, it works.
Okay, thank you. My second question is, in few patients where the history matches very much with a dust mite allergy, or we would expect a pollen allergy, we would do an allergy test and find that they are not sensitized to any of the things, in spite of using a standardized allergens. So how would we take them?
Well, in Spain they are speaking about the local allergic reaction. I'm not a great believer of that. I think that there are symptoms of allergy which are not from allergic origin. So, the problem is how to manage these patients. Well, you are going to use the classical drugs, but you are not going to use immunotherapy. The only difference will be immunotherapy.
Thank you, sir.
Just
I'm Dr. Ramesh. I just wanted to ask you, you said there is no remodeling in nasal allergy. What do you consider polyposis then?
this is different. I'm speaking about allergic rhinitis. Polyposis is a different disease, and I have recently asked, well, it was last week, to my good friend Klaus Backert, is nasal polyposis an endodermal or an ectodermal problem? Because nasal polyposis is not, well, I think that, well, in the 1980s it was said nasal polyposis is from allergic origin, because there were 20 or 30% of nasal polyposis were, but usually those patients with the big polyposis rarely have allergic rhinitis. Would you agree on that?
Here the figures are a little different. We have 50% of patients with polyposis presenting with symptoms of allergy.
Yes,
I mean, it's not a exact study or a statistically evaluated
Yes.
or a double-blind studies sort of thing, but in clinical practice, and most of my ENT colleagues would agree, I think so even Deepak should agree about that, that allergic rhinitis is quite prevalent in patients with nasal polyposis.
Okay.
Except endocrine polyp.
It is possible that we have different patients in Europe and in your country. The second point is that nasal polyposis is not remodeling. It is something different.
Thank you.
So I have a question. How important would you consider clinical examination in cases of allergy?
Sorry, can you...
How important would you consider clinical examination in cases of allergy?
This is an unanswered question, because I know that my ENT colleagues always look to the nose. I didn't do that too much because now I'm retired. I've retired a year ago. So, how many GPs in your country are able to accurately look to the nose?
The reason why I ask is that the application which you were discussing about, it did not bear any importance to the clinical findings at all. It was mainly based on the symptoms. And that's
Yes.
the reason why I asked for this question.
Well, you know, I tell you, when you see a patient, you are not looking to the nose every time.
I do.
Sorry?
I do actually.
Oh, possibly you do because you are an ENT doctor.
But that's because you're looking at the nasal allergy. And we're talking of United Airway disease. And as I said, with great difficulty, the nasal allergy has just come in now. So probably, yes, you have a good illumination, you have the best endoscope. But then when you look at the entire spectrum of allergists, how many of them do it? I do agree with your point, but it will take some time for that to come in.
You know what I was doing? I was treating the patient, and if the patient failed, then I sent him to the ENT doctor. Because the problem is that most patients are seen by GPs, and the GPs do not look at the nose. So this is, you know, when the patient is going to see you, it's a second or third referral. And then you need to.
So is there an opportunity in the app which you created for, you know, a referral system to happen if the patient is not being, the symptoms are not subsiding? Then is there something of an option where he can go and see some? I mean,
Well, it is not in the app, because the app, well, you know that there are regulations for applications which are very tight. You cannot give recommendations on the treatment in an app. Otherwise, every patient needs to sign a document that they are going to use it, at least in Europe and in my country. So in the clinical decision support system in tablet, yes, but not in the app, for regulatory reasons. In which? In rhinitis? None. Omalizumab is a wonderful drug. So the question was, what is the role of omalizumab in rhinitis? Well, omalizumab is a wonderful drug, and it is extremely effective in some highly selected asthma.
Deters a lot of Indians from using for a long period. That's one. Second is, I have found synergy in asthma when you use Allegra M along with nebulization, corticosteroid nebulization. The effect is synergistic both for asthma and for allergic rhinitis. How do you explain that?
Well, montelukast is a drug which is effective in asthma, not in all patients but in some. And Allegra may potentiate this. Well, I have no idea because, first of all, I haven't seen the data published.
Sorry?
The data are published. Publication.
No, this is my personal experience of 40 years of practice.
No, so you know. So I think that if you have this experience, that's very important because the physician's experience is extremely important. So I'm delighted to hear that.
Thank you.
Doctor, some questions in the web from the other meetings.
Okay.
I think I would like to, yeah. How long can Allegra M be prescribed? God knows.
As long as you want. Because there is no safety problem for montelukast, there is no safety problem for Allegra. And these drugs have been given to millions of people for years, so there is no safety problem.
What is the youngest age to use intranasal corticosteroids?
Well, it depends on the country. It is, you can use them at 2 years of age, but I don't know if any, possibly mometazone is approved at 2 years of age in your country.
Any problem of resistance with the long usage of fexofenadine with montelukast?
Well, I would say no. Well, we did that with loratadine. It was 20 years ago. So we did that and we didn't find any tolerance or tachyphylaxis. And with montelukast, at least in asthma, it is the same.
How long can we use oxymetazoline, xylometazoline nasal drops in children with airway disorders?
6 days.
Long-term use of steroid inhalers. How safe for long-term use? How long can we recommend?
Okay. So first of all, there were concerns about the safety, local safety of intranasal corticosteroids. And there have been 3 studies. One of them is from my group. We studied nasal biopsies after a year, and we found that after a year the patients have far better biopsies than before. The second problem is in children. And in children, to give intranasal corticosteroids regularly with inhaled steroids may have some effect on growth or some systemic effects.
What is the relation between a raised IgE level and rhinitis, and what is the medical management?
There is no correlation between, well, it depends what you call by raised. Is it positive IgE to specific IgE? Yes, there is correlation. Is it total IgE level? There is no correlation.
Any other questions, Nikunj? Any other thing from the other web centers?
Yes, one question from this.
Allegra M is not available in the pediatric. The pediatric formulation is not available over here. Any reason for that?
So I would like to answer that, sir. Montelukast dosing is once daily, whereas Allegra suspension is twice daily dosing. Because in pediatric, the population, the fexofenadine metabolism is faster than adults. So because of that, formulation cannot be developed until unless we come up with a formulation which prolongs the duration of fexofenadine for 24 hours in children as well. So we are trying to work for that. Probably a delayed release kind of formulation which works for 24 hours in children will be a solution.
3 more questions in the hall. In case of persistent urticaria, how long can we use fexofenadine?
Same time. Well, I'm not an urticaria doctor, so I cannot comment on that. But the safety and tachyphylaxis are quite well demonstrated. So no tachyphylaxis, great safety, so no problem.
The safety profile of fexofenadine in pregnancy and lactation.
I'm not sure that it has been really studied, but the experience is that there is no problem. Lactation, I would not be so sure, but in pregnancy, I am pretty sure.
Use of fexofenadine in an elderly patient with benign prostatic hypertrophy.
With?
BPH, benign prostatic hypertrophy.
No problem, because there is no anticholinergic effect. Wow, question are floating.
What is the role of the recently introduced molecule bipotastine in ARIA guidelines and in general allergic rhinitis?
No idea, I don't know this molecule. It's not marketed in Europe to my knowledge. Sorry.
Comparison of the high dose of fluticasone nasal spray versus oral corticosteroids in patients with united airway disease.
Try to avoid as much as possible oral corticosteroids. You know, there is a line in the question I'm trying to answer with a line.
According to the follow-up, how long can we use fexofenadine montelukast combination in united airway disease without major health hazards?
I think that we answered this question a long time. Well, there is, I don't see why there would be a problem in long-term use.
And after using Allegra M for some time, when would you switch over to immunotherapy? And what are the results of SLIT versus SCIT, S-C-I-T?
Well, first of all, I prefer SLIT than SCIT because of the data which have been provided. Secondly, in children, a syringe is not optimal. Secondly, I would not start immunotherapy just after Allegra and montelukast. I would do a course of intranasal corticosteroids.
Any other questions? We call it a day or call it night? Thank you, Professor. Thank you.
My pleasure.